I think we are now approaching the last session of this Goa conclave, and to chair this session, may I invite Dr. Sandhya Suresh from Chennai, Dr. Vineet Behera from Mumbai, Dr. Ravindra Prabhu from Manipal, and Dr. Sri Lata from Calicut. The session is a panel discussion on pre-transplant cardiac screening of recipients. How far do we go? And it will be moderated by Dr. Zaheer Virani. May I invite the panelists for today, Dr. Sharad Sheth from Mumbai, Dr. Subhashri, and Dr. Kayan Siodia. Dr. Kayan is the cardiologist and would be the center of attraction today in this panel discussion. Is Dr. Suhas Bhavikar around? I think he had to leave. Over to Zaheer. We have 30 minutes of panel discussion, 10 minutes of chairperson's interaction.
So we are going to start and end on time because we don't want anybody else to miss out on the evening beach. Also, we're going to just do a little bit of a modification. So said we're going to give 10 minutes to the chairpersons, but we're going to give all the time to the panelists and the chairpersons, because this is basically an area where everybody's always fighting with the cardiologist or the anesthetist for fitness for their patients. So let's hear what everybody has to say about their practices in their hospital instead of me just going on a monotonous journey down this road. So, yeah, the slides are up. A 50-year-old male, Mr. Left main, diabetic for 20 years, hypertensive since 20 years, chronic kidney disease since the last 10 years. On maintenance hemodialysis for 7 years, thrice a week, no symptoms during dialysis. Was planned for a kidney transplant. The wife was a donor. Being the wife, obviously, there was no match. The ECG was within normal limits. The 2D echo showed a grade 1 diastolic dysfunction with preserved left ventricular ejection fraction and no regional wall motion abnormality. Now, when this sort of case comes up for a transplant, we obviously have to get anesthesia and cardiology fitness. And these are the various tests available to us. So first I'd like Dr. Sharad Sheth, sir. So what are the practices in your hospital if you come across a diabetic hypertensive patient with no history? How would your team evaluate him?
He's 55 years?
Yes, sir.
So
this is the case, sir.
I am in a corporate hospital.
Right.
Wherein the fitness is a big issue. And I have to refer to anesthetists and cardiologists as a protocol before transplant. So this is a must for me.
Right, sir.
And also I feel because there are traditional and non-traditional risk factors. I've been diabetic hypertensive for more than 10 years. And as to say that all diabetics essentially have to have angiography before transplant.
Right.
And especially why do we doing transplant? To give him a good life for at least 10 years post-transplant. If we have not assessed his cardiac status properly, and if we were to develop a cardiac event just within a couple of months after transplant, successful transplant, it would be a disaster. So I think this is a must, this case, for a cardiac evaluation. Angiography. Straight away. No, straight away angiography. Yes, with a diabetic with multivessel disease.
No. I will reply to that. I have been doing myocardial perfusion scan for more than 26 years. So 25 years back, whenever those patients on dialysis, we refer to cardiologist, he'll always do angiogram. But those patients in angiogram, he showed triple vessel coronary disease. Those who were asymptomatic, I referred an outside hospital for myocardial perfusion scan. And more than 20 patients who had triple vessel disease, more than 90% stenosis, when myocardial perfusion was negative, I did not allow him to do cosmetic angioplasty or cosmetic bypass. And not one of them got MI in next 1 year. So we are doing a myocardial perfusion scan for all asymptomatic patient dialysis for last 20 years once it came to our hospital. Angiography only if cardiologist strongly feels, in spite of a negative myocardial perfusion, this patient does require angiography, or symptomatic patient, history of MI, you know he's got angina, that is different. But asymptomatic patient protocols are different, because even if normal society, we start doing angiography everybody, so many fellows have blocks. So just cosmetic angioplasty or cosmetic bypass may not help.
So we'll let everybody else speak first, and then we'll let Kayan, who's the cardiologist, speak, so that we know how diversified and how different everybody approaches their patients. So Kayan, I'm sorry I took the mic away from you.
We have a cardiologist also, and also a nephrologist who is working in a government setup. We'll take a view, and then we'll throw the question to the audience.
Oh, you want to go that way? Okay, so but Kayan will give you the answer then.
Yeah.
Because he's a guidelines-driven guy.
Yeah, Kayan.
Go ahead, Kayan.
Can I just had a comment here.
Go ahead.
So there was this landmark trial called the ischemia CKD trial,
Right.
published by Charles Herzog. It's an international trial.
Right.
I happen to be the lead author from India, and we looked at all our patients, and it clearly showed that if you are placing these patients on the wait list for transplant, pre-transplant cardiac evaluation did not have any benefit in the mortality outcomes. But the problem is, I also work in a corporate hospital. Our cardiologists refuse to give us. So we are literally hounded, into getting these angiographies done. So that's the
Right.
other
So
side
I
of the
will
story.
just
But
interrupt
I've
you.
just given you the literature support for this trial.
No, you're right, sir. And the AHA guideline, which came out in 2022 in November, which I was also made to read after Dr. Umesh Khanna sir gave me this opportunity. So that's what Kayan is
This
going to update
November
you on.
22,
Yes, yes, there it is.
in circulation,
Right.
for CKD, ischemia CKD. But that is for disease donor wait listing. Here we have a live related donor.
We were a part of the trial, and we had the live-related transplants are very much a part of this study. Okay, there's another paper on disease. There was
77 patients, and that is for disease donor.
no. There were two arms. We were part of the live-related this thing, and
I think you all are quoting two different trials. He's
Yes.
talking about
No, so now we let Kayan take it. Yeah, Kayan.
Actually,
this is
sir,
the
as you
Journal
said
of
about-
American College of Cardiology, if somebody is interested, July 2021 issue. The one I
Well, sir, I absolutely agree with the ischemia CKD trial. It actually very specifically states, it's the 2019 which came out, which specifically states anything less than moderate disease, revascularization will not help, GDMT will help. But it is moderate. Please be advised, it is written very clearly. So that caveat still remains. The other caveat in that was the endpoint was mortality. At no point in time did they ever state that pre-operative or intraoperative or post-op there were any differences seen in revascularized and non-revascularized group. Coming to the 2022 November guidelines of the AHA, they did a very wonderful thing which actually brings out, as sir very specifically put, cosmetic angioplasty. So they changed the term coronary artery disease into coronary heart disease. So at no point in that guidelines will you see CAD written, it is CHD written. Why did they do that? As sir said, what you see on a coronary angiogram is the epicardial vessels. You do not see the microvascular circulation. So you cannot comment on that only by an angiogram, number one. As for this case, I would actually advise the dobutamine stress echo rather than any other, modality as step number one. In this 2022 guidelines, one more thing was very specifically added, which was different from the 2020 guidelines, which actually states that risk factors which are ubiquitous to CKD, that is your hypertension, diabetes, peripheral vascular disease, should not be considered additional risk factors. That is very important for us to understand. So these are not taken as additional risk factors. So this patient, I would not put through an angiogram. First and foremost, I'll put through a dobutamine stress echo. When I talk about dobutamine stress echo, these tests are physiological basis. When I do a CT coronary or an angiogram, these are anatomical basis. So even if I find that the anatomy is clean or the anatomy is disease, it will never give me the idea of a physiological disease in the patient. So that is actually two differences that we very well need to understand. And as sir said, myocardial perfusion scans, there is a very big problem with that because the pre-test probability should be very high in these individuals. So if you feel, then the MPS will do, while a DSC has a better sensitivity and a specificity than an MPS. So that is something that I would like to state.
Why not just straight away a treadmill? Why do you want to go to the, you said, dobutamine. Do a treadmill, And if it is positive,
I'll get back to you. So treadmill, no.
pardon?
No, treadmill can be
we
done.
do all the
I
time
agree.
treadmill.
I absolutely give sir that. But a treadmill, again, the sensitivity and specificity is very poor, number one. Number two, false positive, I would rather put it as it is observer variation is very, very high. So there is something called the treadmill test index, which can differ from the same cardiologist seeing the same TMT at different point in time. As you're going for a transplant, I would rather not take that 2% chance of inter-variability and put the patient through a DSE, which is more specific.
Other way around, rather than TMT, those asymptomatic patients, we did the myocardial perfusion scan, it showed ischemia. It was confirmed by coronary angiogram. We did not find it negative. Coronary angiogram also showed a hidden disease, which required angioplasty or bypass surgery. I'm talking of only of asymptomatic patients. TMT can be false positive, false negative, but myocardial perfusion was very sensitive.
So DSE and MPS, yes, I agree with you. Where this is concerned, that changes substantially. But even if you do a coronary angiogram, for example, you find a circ lesion which is 90%, would you revascularize or would you not revascularize is the question which comes. So you again go into a dobutamine stress echo or a myocardial perfusion scan, see whether this is moderately high, low risk, and then go ahead even with a 90% circ lesion. I have given fitness for a 90% circ lesion and the patient's doing wonderfully well.
And I was in a government institution what Sanjay was talking, and we went through a spell when we were very liberal in doing angiographies. Whether the patient was symptomatic or not symptomatic, if he was diabetic, if he was older, angiography was done. And then it was stopped because we realized that we were reaching nowhere. But I would like to tell you that it's not that simple. These patients are having a sedentary lifestyle. Many times they are not symptomatic. At present, I am in a corporate hospital. All these patients go for, recipients go for cardiac clearance. And as you are mentioning, dobutamine stress echo is a standard test which is done on all these patients. Besides a clinical assessment, the problem with the myocardial perfusion nuclear scan, which we used to do when I was in Sanjay Gandhi PGI, we found that it was difficult to interpret. Many times when they used to say that it's not significant, we thought patient is symptomatic and he has significant problems. I think if a patient has symptoms, if there is a history of coronary artery disease, these patients must be subjected to coronary angiography. Recently, we had burnt fingers with 2 patients in just 3 months' time. The first was a young patient who was cleared after the standard test which you are mentioning. He was going for surgery, and just when the intensivist was inserting the central line, he had pain. And when he had pain, we found that he has had actually acute MI. And the surgery was postponed. Before that, he was given clearance after undergoing angiography because the cardiologist deferred, as you are mentioning, 90%, 89%, 70% stenosis. So what I am trying to say that these patients are a different type of patients where we have to be careful. Another patient who had undergone angioplasty, he was cleared after the dobutamine stress test. Within a month of transplant, he had an acute MI. And he has had a coronary angioplasty. And within 2 weeks, he has had second acute MI.
So they will always...
So I'm trying to say that you have to be more careful.
Yeah, you have to individualize. The guidelines are a rough guideline.
Even the guidelines will not be...
Yeah, that's true. But we have to have a book which... Sorry,
just going a little into technicality, when we talk about, there is another component of myocardial infarction called myocardial infarction in non-obstructive coronary artery disease, which you will see generally I'm putting this forward because you see this generally in young CKD patients who have Prinzmetal angina, who have severe vasospasm of the left main, which can actually lead to an MI. And when you do an angiogram, it's absolutely clean. So it's actually classified in the universal definition of MI type 2. And this is a known phenomenon. So that's what I'm just coming to.
Okay. So Kayan, you're going to have to spend some time on tea with Sir. Yeah, so that we can finish this. The chairpersons have a comment, or should we go on to...
So I think we should go ahead, and as he
Fair.
told that we should do a stress test, and if it comes positive, so we do a coronary angiogram. So how do you go further? So if we...
so
if
which
we find
lesions do you
acute disease-
revascularize, Kayan? You almost answered that in the last one.
Exactly. So I would not go by the anatomy
Yeah.
basis because then as you...
Right. So now
actually
what...
take these questions so that...
Right. So let's talk about the duration of dual antiplatelets. Now you've stented this guy with the drug-eluting stent because that's what you normally do. So how long after a stenting would you allow us to go in for a transplant?
There are beautiful new stents which have come into the market, especially by the Medtronic. I hate to name it, but they actually have come out with a trial where you use dual antiplatelets only for 1 month. After 1 month, you can stop dual antiplatelets and keep them on a single antiplatelet, plain ecosprin, and do your surgery even after a month and a half. So 1 month is all that's required for dual antiplatelets. Go ahead and then finish off your transplant.
Okay, and the normal stents which you use?
It's normal, it's available.
And the CKD patient rather than...
Right.
Absolutely, sir. Onyx stent is proven in CKD patients. They've done a multicentric trial of 29,742 patients.
So
it
what
is found
Kayan-
in one month of dual antiplatelets, then you can put back the patient on single antiplatelets.
So what Kayan is saying is the same thing that I read in the guideline.
It's available. It's available. The Medtronic stents are available.
It's coated, sir. It's a newer
Drug-coated,
generation of
drug-eluting
everolimus coated stents, if I'm not mistaken. Yeah?
Sirolimus.
Similar, yeah. Everolimus. Sir.
Our cardiologist...
Sirolimus, my mistake.
Sir, ideal. So we have this guidelines where actually requirement is 1 year, but if the patient requires any surgery, dual antiplatelets can be stopped as early as 1 month. Put the patient on a single antiplatelet and go ahead and do it.
Yeah, I think our cardiologist perhaps use the same, I don't remember the name of the stent, but we are using only for 3 months, avoiding the stents which require for 1 year. Otherwise, patient will die of money on dialysis. He will not be having a transplant after 1
Sir,
year.
you're absolutely right. So I'm sorry.
After 6 weeks of dual antiplatelet, we have done transplant, we have stopped, and after the transplant is done, they are back on dual.
6 weeks. So 1
Does
month
the
is...
November guideline answer this?
Yes. The November guidelines says exactly what he's saying, the AHA one. Actually, that should be one thing that everybody should read and then quote it to their cardiologist. So now, can we operate on ecosprin, clopidogrel, ticagrelor, prasugrel? Which one is it safe? And how long do they need to be off these drugs so that we can operate?
So the last two are irreversible ADP inhibitors. I would absolutely avoid ticagrelor. Prasugrel is an absolute no-no. Clopidogrel and ecosprin, there has been debates. So the only thing is that ecosprin has been studied for much longer than clopidogrel. So keep the patient on a single ecosprin. Go ahead and do it. Number two, where clopidogrel is concerned, Indians have been found to be fast metabolizers. So the chance of antiplatelet failures are high with them.
So you'd say that best drug would be ecosprin. Just keep the ecosprin and go ahead with the transplant.
Absolutely.
Okay. Okay. When to stop antiplatelets before kidney transplant, you almost answered that question. When to restart the antiplatelets after transplant? Now, like Sir said, that in his cases that after 6 weeks, they go ahead, they do the transplant, and then how many days after surgery would be absolutely essential to start? Or if there's no bleeding, you start after 48 hours?
As soon as hemostasis
As soon
is
as
achieved.
possible. Okay.
Go ahead.
Are there any reversible agents for antiplatelets? So suppose now, just for example's sake, it's a disease donor transplant. And this guy is already about 6 months post a coronary angiogram, didn't come for follow-up, an angioplasty. Would you still take him up or would he be denied?
I'm sorry, I didn't get to.
Okay, let me go again. This gentleman got a disease donor program and he got a transplant in the middle of the night. We haven't had chance to stop his dual antiplatelets. So he's already on ecosprin and clopidogrel. Would you still be brave enough to give us permission to operate or no?
Absolutely, go ahead. The only thing, just going a little ahead of it, now we have IV antiplatelets available on the shelf, IV cangrelor. Okay. The T-half of that drug is 3.5 minutes. So if you feel that you have to transplant the patient, you can stop clopidogrel, ecosprin like 5 days ago, put the patient on IV cangrelor as an infusion, stop 2.5 hours before surgery, and put him back post-op. So if that's available, then everything's sorted. You don't even need to take care of that.
Go ahead,
The surgeons might have a problem.
Yeah,
if
they'll
they-
ask for
if
his
the
fitness.
So
T-half is 3.5 minutes, sir.
no, the patient is on ecosprin and clopid. So the transplant has to be done in the next 2 hours. So I'll ask both the panelists. So what would they do?
We'll do this program for all the cardiologists of the country.
Yeah, so before answering that question, I actually would like to ask this question to the cardiologist. How do you assess what is the bleeding risk in a patient who is planned for transplant?
Has bled.
What are the parameters that you look into? Because we do, like the 2020 guidelines of KDIGO actually is based on your HA 2012 guidelines on doing all the guidelines on non-cardiac surgery. After that, we had the European best practice guidelines, and recently in 2020 we had all these questions actually have got very precise answers in your European Society of Cardiology, which has been endorsed by European Society of Anesthesiology also, when to stop and when to restart, at which hour to, and that particular guidelines, actually after reading that I kind of knew about the cangrelor drug. But my question is, how do you assess this particular patient has got a high bleeding risk or high thrombotic risk during the surgery?
So the 2012 guidelines that you're talking about was adapted by Ravel et al., where everything was angiography. Everything was anatomical based. There was nothing physiological based, number one. Number two, coming to the question on the antiplatelets, it depends on, there are many, calculators, risk calculators for bleeding, has bled, your Lee score, your RCRI. So these risks are important. However, if you're getting a donor in the middle of the night and the scarcity of the organ, you're not going to stop a donation just because you're on dual antiplatelets. Give him platelet concentrates. That's fine. Because platelet concentrates half-life is 4.5 hours. So that's not going to change anything much about my stent. And then you can just immediately put him back on IV cangrel or post-op. So that makes sense, So this was actually addressed, this same question was actually addressed by Lee et al. In 2021. He had a paper on this similar question which you asked, but it was for other non-cardiac surgery.
Because we are aware of all this Has-Bled score and for CHAD-VAS score, but at least my perception was all these are applicable in patients who had AF. So
No, these are just bleeding. These are bleeding risks. These are not only specific to that. So CHAD-VAS is actually AF specific. Has-Bled and other Lee score, RCRI and all are not specific for. And they're mostly for NOACs, but can be interpolated even for antiplatelets.
So we're going to move on a little bit, and again, these are the three drugs which cardiologists love, and there is some debate in our...
And SGLT2 also, no?
And SGLT2 also, yes. So, So SGLT2, most of the time, now it's come in that you can continue till dialysis, but otherwise you wouldn't see so many patients on SGLT2 when they're about to get transplanted. But statins is one thing because we've been seeing, because of the coronary angiograms and the angioplasties done, ACE-ARBs and now even the ARNIs, the netilirsin inhibitor and the valsartan combination and the beta blockers. So what's your practice in your institute regarding these three?
I'll just take one question at a time.
Yeah.
Question number one, statins. The LOAD trial actually says that if the patient is not on statins, you need not restart statins. They do not change the outcome of the surgery. Number one, they were very specific on this. So statins is more like a long-acting, the pleiotropic effect of statins, that is your anti-inflammatory action, is going to take time to act. So don't start preemptive statins, just pre-op. Number one. ACE-ARBs, if the patient is on ACE-ARBs, the pivotal trial actually says if the patient is on ACE-ARBs before that, before your transplant, you can continue that. But I'm not the best judge. I'm not going to dwell into it much because everybody is well educated where ACRBs are concerned, and probably I can know better.
So even our latest trial said that the stop ACE trial said don't stop the ACRBs. So we agree with you unless there's refractory hyperkalemia. So then that's a different game altogether.
And the last point of beta.
Before transplant or just after transplant, most of us stop ACE or ARB for a fortnight to 1 month till the renal functions normalize.
Agree with you, sir. Agree with you, sir.
Risk of hyperkalemia.
So you just don't want to be confused why there's allograft dysfunction. Bottom line, right? Okay. Right. Then you're confident. Then yeah, fair enough. Sorry.
And I think that has been also reiterated in the AHA scientific statement in 2022.
Right.
They do advise that the ACRBs can be continued, but we should exercise caution, and preferably we can restart it once the renal function and the electrolytes have stabilized post-transplant.
So individualization.
Do you recommend initiation of statin after transplant?
There is no data on that, madam, frankly.
After
If the
transplant
patient,
for cardiac protection, most of our post-transplant
ma'am,
cause of
first
death
and
is cardiac.
foremost, cardiac statins, preemptive cardiac protection, there is no data. Let me be very clear on this. There is no preemptive data in a patient with normal lipids having any benefits by preemptively starting
But you recommend
statins.
statin for all diabetics beyond 50 years of age for primary prophylaxis.
There is no primary prophylaxis for statins, madam. If the patient's lipid profile is normal, lipoproteins are normal, you do not start primary statins because they themselves have their own risks and problems. So if you feel that there aren't any issues, I would not start statins preemptively for a 50-year-old at least. Getting to the point of beta blockers, beta blockers are wonderful because they decrease the sympathetic tone, but it is very clearly stated it should not be started within 24 hours prior to surgery. So if the patient is on beta blockers, you continue your beta blockers, but do not start them 1 day prior to the surgery. They can be started post-op immediately.
So I have one last case, and we're going to go through this very quickly. And this was only put up because this is another problem which we all come across. So it's a 25-year-old female, end-stage kidney disease, secondary to acute, a mechanical aortic valve replacement, secondary to infective endocarditis, preemptive kidney transplant. Donor was the sister. Patient was on warfarin. Okay. Basically, the ECG showed no ST segment depression, T-wave amplitude reduction, and LVH pattern. So I'll just get to the question scan so that we don't disappoint Dr. Umesh Khanna because we have only 4 minutes left. So what would you do next? Now, how the basic idea of this question is, what do you do when you're on an oral anticoagulant and a patient is for transplant? Sorry, my mistake. Do you want to go back and see the first part?
Yeah.
You got that? Okay.
Next, immediately measure your bleeding parameters, your PT-INR, get your PT-INR less than 1.5, till then put the patient on Clexane, overlap, keep the patient on Clexane, do your transplant, put the patient on Clexane again, overlap with warfarin, and after the INR is 1.5, stop the Clexane. Very important, very, very important, the overlap part.
And what is the role of newer oral anticoagulants in mechanical valves?
Absolutely zero. There is data which actually proves that NOACs used in mechanical valves actually increase the thrombogenicity of the valve. So NOACs, as of today, are not indicated in mechanical valves.
Clexane we avoid in dialysis patient, not use it. Not.
What I mean is, sir, dalteparin or something of that nature. What I meant is LMWH,
That's what we follow
sir.
for 3 days before.
LMWH can be given, sir.
Or we can use unfractionated heparin, but there'll be lots of poking, yeah. And the drug interactions with immunosuppressive agents, I don't think we should push it to CAN, but anybody else in the chairpersons or the panelists, have you had any experience of any problems with using newer oral anticoagulants and immunosuppressive agents in any of your population? When I went through the literature, I didn't find any, at least with Apixaban, which is the one which is preferred among nephrologists, there is no interaction between tacrolimus and mycophenolate mofetil. We had this problem in the middle when there was a COVID pandemic, where everybody wanted to give anticoagulation, and like Sir said that we were challenged to give Clexane. So lots of people in our transplant population ended up being on Apixaban and tacrolimus and mycophenolate mofetil. So anybody's had any experience with that? Any bad experience? Because the literature says there's no interaction.
I think Theoretically, there is an interaction because apixaban and rivaroxaban are substrates for CYP3A4 and also substrates, all of the newer anticoagulants are substrates for PGP. So theoretically there is an interaction, but they have graded it as a category B interaction. So there is no necessity to avoid the combination of these drugs. So in many patients in COVID especially, we have seen apixaban being added for transplant patients. And we have preferred apixaban because it has the lowest renal clearance of the 4 NOACs that we have.
So we're done, now it's your turn.
No, I think, yeah, I think anybody wants to add a comment, we still have about 5 minutes.
It's not a comment, just an impression in my mind from practicing nephrology for a long time. 1978, started doing transplants and no cardiologist. Physician will see, and the nephrologists also happened to be good physicians those days. And say
so even
that...
Even these days, physicians are not called by nephrologists more often.
So, we'll give fitness for surgery. And it happened for about 10, 12 years or so. The cardiologist, echocardiograms came in, and for another 10 to 12 years, the cardiologist gave consent on the basis of echocardiogram. 2005 or 2007, I started associating with the cardiologist who wanted treadmill angiogram. Before this association, we lost one patient immediately after the transplant due to myocardial infarction. Since the time we started associating with the angiogram doing work, we have not lost any patient intra-surgery or immediately post-operative, but at least 30 to 40 patients have not had a transplant, have stayed on dialysis, left dialysis, or died during dialysis. I really do not know whether we need all these things.
I think any comments from the chairpersons about anything to do with this session?
What about cardiac CT? Because there's some, or combination of CT with perfusion scan.
CT sensitivity is only 52%. So if you find that there is a lesion in the CT, you will never be able to grade by the CT what the lesion is type. So if they give a 60 to 70% lesion on a CT coronary, I have to do a normal angiogram because I cannot know the. So as I said, if you want to put 200 cc of dye for a CT coronary, why not me go and do a 25 cc dye and finish it off in a CKD patient? So CT coronary is something which is left to last. It is only when your pre-test probability, like you have a 50-year-old lady as his example, where the chances of her having a coronary lesion is very less, then you may consider a CT coronary, doing a CT coronary. So once your CT coronary is clean, you don't even need a DSC actually. So
a diabetic who has already a CAD is awaiting transplant. Is coronary angio is a must? History of CAD is there.
If the patient is CAD, if the patient is stented, if it has been more than 1 year, still do only a physiological test. If the physiological test shows that there is a problem, then go do an anatomical test in form of an angio.
That's all what is required.
Absolutely, absolutely.
The AHA 2022 November issue, which everybody seems to have read, is basically got 2 tables in it. And it's very simplified. Patient with coronary heart disease, patient without coronary heart disease, history of coronary heart disease. And then they just simplified the whole discussion actually, like Dr. Umesh Khanna said, there should have been more cardiologists around. So Kayan's the exception to the rule.
KDIGO latest says that discuss case by case decision, discuss with your cardiologist.
That's why we got only one.
Dr. Kayan, can I ask a question from here in the audience?
I'm sorry, thank you.
2 things actually, 2 questions. So the first one is patients who are not getting sirolimus coated stents. How comfortable are you in those patients, and how many months after the stenting would you stop the second antiplatelet and go for transplantation? And the second question, I just want to clarify because you already mentioned it when you were telling that normally we just follow like a 3 to 5 days overlap with heparin and when we are shifting to warfarin. But you specifically mentioned we have to wait till the INR should be 1.5. So is that the current practice by cardiologists?
Absolutely, because when you give warfarin, they tend to act as a coagulant for the first part because of the protein C activation. That is very important. We generally tend to forget that. That's why you overlap with Clexane, or sorry, LMWH, dalteparin or something of that nature, till the INR is 1.5 and then stop the LMWH.
So we normally used to overlap for the 3 to 5 days, but we
It's
wouldn't
not 3 to 5 days, ma'am. It's till the INR is more than 1.5.
Okay. And what about the first part of
And the first part, now we have only drug-eluting stents. And we should not be looking on, the concept is different. We should not be looking at only the drug which is in the stent. So we have zotarolimus, we have everolimus, we have sirolimus. It is the stent strut size that is also very important and is thrombogenic. So the Medtronic stent which I spoke about, in 1 month you can stop, has only 100 micron stent size, which is very, very small. So that's why you can stop it in 1 month. The other stents have data on 6 months follow-up. So within 6 months, you can stop dual antiplatelets, put them on one. However, the ideal, as is actually written down, should be 12 months of dual antiplatelets.
Okay, thank you.
Replying to Dr. Ramlingam, if you look at the late 80s, figures of post-transplant patients all over the world, diabetic especially, I'm talking about recipients, the mortality was quite high. And I have seen that in the country also. Mortality significantly came down when cardiologists came to the picture intensively. Whether they did angiography or they did the myocardial scan, when the patients were properly evaluated, not only question of angioplasty, beta blockers, statins and ecosprin, the mortality did come down. Mortality was significant. One more caution, post-transplant patient, when they come with angina, acute coronary syndrome, I think ecosprin and clopidogrel are better than Brilinta or Prazopil, because I have seen 4 TMA-like lesions last 1 year. Creatinine goes up, you have to stop it, continue with the ecosprin clopidogrel, and the patients recover. So that's a caution for everybody whose patients require angioplasty or stenting post-transplant patients.
Well, I think, yeah.
I have a couple of questions. First is to you, sir. You touched upon the type 2 MI. So the type 1 MI, the plaque rupture, does any of these screening tests predict that?
Absolutely. That's why they have brought this into the guidelines, that you do not miss a left main. A patient may have a normal echogram. A left main, a 50 to 70% left main lesion can have a normal echo. That is something that we need to understand. That's why you have to put the heart through stress so that you can, reveal these left mains. So you should not miss these left mains, valvular lesions. That's why these echoes and dobutamine stress echoes have come into play. So that's important.
And another one for the general audience, like how many of us have cardiologists who attend our transplant meetings?
Hardly anybody.
No cardiologist attend any meeting.
He's right here.
So anyway, that just shows how popular Kayan has become. Yes, Manish.
Yeah, it's regarding the, we are discussing about the formal physiological testing of the heart before subjecting them for transplant. So now we are having, discussing about a subset of patient who is undergoing dialysis 3 times a week, who are tolerating 3 to 4 kgs of fluid overload during that 48 hours period, who are getting subjected to variations in the blood pressures during dialysis, hypotension or accelerated hypertension. So can we extrapolate this as an informal physiological test? Because we are thinking about the patient undergoing anesthesia for 3-4 hours. Or can we do anything, or can we stress hard during dialysis where monitors, everything is available, and we can have not a formal stress test or a dobutamine stress test, but something like a...
Getting a transplant kidney, very clearly it's written, it's a scarce organ. So you would not want to have a non-physiological or a proven data. As you said, wide fluctuations during dialysis is an indicator that there is some amount of coronary, because there is perfusion mismatch. So that can be taken as an informal, but cannot be substituted for a dobutamine stress echo. That is for sure.
You can do a trial and see. That's the only way to prove it.
since we are discussing little off the track, what is your approach for patients having pulmonary hypertension? At what level you will recommend to be accepted? Many times cardiologists put it that the person has got severe pulmonary hypertension, 60 millimeter or 65 millimeter, we will not accept. Sometimes the moderate they accept. What should be the message?
Okay, so as per the new guidelines, a systolic pressure of 65, more than 65, should be treated before transplant. Now, a CKD patient, they have found data, there was a large Israeli trial in CKD patients, where they found that there is some amount of dysfunction, endothelial dysfunction in the pulmonary vessels, which take place, especially a patient who is long-standing CKD, which has been into, if I can use the term uremia, please forgive me if I'm being ignorant, but when the creatinine has been high for quite some time, then they have vascular changes where the pulmonary pressures are on the higher side. So a severe should be taken down to moderate. So there has to be one class difference before taking up for transplant. So you can...
Is it you put them on sildenafil?
Sildenafil, tadalafil, ambrisentan, safe.
And how much time roughly it takes?
So the guidelines actually say put them on a combination of tadalafil plus ambrisentan, get them down by 1 degree, repeat echo after 3 weeks. If they come down, then go ahead for the transplant.
I think we'll have the last question from Manish.
Slightly off track, kidney biopsy on dual antiplatelets. It's a dilemma which we come across, all of us come across. A PTCA patient coming to you with AIN, or let's say AKI post PTCA, not recovering, and you suspect something other than contrast. Now this is 1 week or 10 days after a PTCA, and the patient has almost become dialysis dependent, and sometimes with normal renal function baseline. So how do you approach this? And a transjugular kidney biopsy is not favorite of any of nephrologists. So it has to be a percutaneous one. So how do you approach that?
Very good question, sir, because I got into a scuffle with a nephrologist who is sitting in the audience in the same matter. So with the invent of cangrelor, this is absolutely out of the picture. So even after PTCA, immediately, if you want to do it in 1 week, stop the antiplatelets, start IV cangrelor, take him up after 3 to 5 days, depending on what dual antiplatelet patient was on, do the biopsy, and put him back on dual antiplatelets.
Friends, you will all agree that this session seems to be winning the most popular session of this Goa conclave.
Well, like my DM exam actually, but that's okay.
So 3 cheers to the cardiologists and the entire team who brought this discussion to that level.
We should really congratulate the cardiologists for making all the doubts clear.
Yeah, but I would thank Zaheer and the entire team for making this session very lively and entertaining. And please accept my congratulations that we are still sitting at 5 o'clock and we have to close the question answer session, not because the people are not enthusiastic, but because the time has come. So thank you everybody. It was